Hello everybody, let me introduce my PhD thesis, fertility-sparing treatments in gynecological cancers. And I found this. So, a quick summary. Cervical cancer affects and strikes many young women in their reproductive years. Below 2 centimeters, fertility-sparing treatments work well. But once tumors grow beyond 2 centimeters, guidelines say no to fertility sparing because these cases would require more radical surgery, reducing pregnancy rate to just 8%. Our systematic review and meta-analysis challenged this barrier. We found that adding neoadjuvant chemotherapy can shrink the tumor and thus less radical surgery become possible while maintaining the oncological safety. Therefore, women who wish to maintain their fertility should be offered this combined approach. And this is a whole field alternative for women who dreaming of motherhood. So, my name is Ádám Vincze. My supervisors and I share a vision that we would like to live in a world where women can keep their ability to reproduce even after the appropriate oncological treatments. We want to find the best fertility treatment options for these gynecological cancer patients. We have 2 specific goals in mind. The first one about cervical cancer and the second one about endometrial cancer. The first topic is titled Investigating the Efficacy and Safety of Fertility-Sparing Treatment in Early-Stage Cervical Cancer Beyond 2 centimeters. A bit of background. Cervical cancer is the 3rd major oncological death among women. 40% of it is diagnosed in the age frame, and fertility preservation is key. Fertility preserving surgeries like colonizations or trachelectomies are oncologically valid alternatives in those early stages where the tumor size is below 2 centimeters. The problem is where the tumor is become too big, it's too large for the upfront surgical approach and the pregnancy rate drops dramatically. The idea is, with the help of neoadjuvant chemotherapy, we could shrink the tumor and potentially downstage it for a less radical surgery. Our aim to find an oncologically safe and fertility-wise sufficient fertility treatment options for these larger tumors. So our clinical question is, what is the best fertility sparing options for these larger tumors? And we're investigating neoadjuvant chemotherapy followed by surgery, compared it to the upfront surgery. We're interested in oncological and fertility outcomes. According to our hypothesis, the combined approach provides better results. So, among 3 databases, we found around 12,000 hits. Our search key consisted of 2 domains, the first one about the disease and the second one about the treatment options. After a careful selection, we arrived to 19 eligible full texts. This slide shows the forest plot of the pregnancy rate, which is a great outcome to assess post-treatment fertility. It shows the proportion of women who got pregnant. The scale ranges from 0 to 1 or 0 to 100%. 0 means that nobody got pregnant, just like after a hysterectomy, and the higher values mean better fertility. We analyzed 2 cohorts. The one included around 50 and the second one around 180 patients from observational studies. And the heterogeneity was I-squared 0%, suggesting low heterogeneity, but the confidence interval was quite wide, meaning that we cannot rule out meaningful differences between studies. The pooled pregnancy rate for the upfront surgery was 8%, and for the combined approach it was 31%, meaning that 8 versus 31 women out of 100 got pregnant. This difference is clinically meaningful and statistically significant between the 2 groups. This suggesting that the combined approach has a potentially better fertility after the treatment. This slide complements the prior one. It shows the recurrence rates, which is a great metric to assess oncological safety. It shows the proportion of women who relapsed after the treatment. Now, the desired outcome is 0, meaning that nobody relapsed. And for the context, the same population would experience below 3% recurrence rate after a hysterectomy. So the analyzed cohorts now contain 130 and 180 women, and the heterogeneity remained the same, with the same sources of heterogeneity, meaning the small patient number, the small study number, and the fact that some women, so the different chemotherapy regimens and surgical methods. The pooled pregnancy rate, the pooled recurrence rate for the upfront surgery was 10%, and for the combined approach it was 13%, meaning that 10 and 13 women out of 100 relapsed respectively. This difference, importantly, is not statistically significant. This means that it's not statistically significant difference. And given that the combined approach has better fertility after treatment, this should be offered for women who want to avoid the guideline-proposed hysterectomy. So our study strength lies in filling the literature gap by providing data and evidence on fertility-sparing options for this highly specific narrow population without the influence of additional treatments. It has limitations, the high heterogeneity, the small patient number, and the fact that the articles used were mainly observational single-arm studies. So we can conclude that based on our currently available data, neoadjuvant chemotherapy followed by surgery may lead to higher pregnancy rates without compromising oncological safety compared to the upfront surgery. The implication for practice that patients who wish to maintain their fertility even above the 2 centimeters threshold now are supported by evidence, and it challenges the conventional fertility sparing criteria and promotes personalized patient-centered care that respects patient priorities. The implication for research is that we need more prospective trials to enhance the level of evidence. The manuscript is currently at the final stage. We're trying to finish it as quick as possible and submit it. The first choice will be the Gynecological Oncology journal. And just a quick summary about the second topic, investigating the efficacy and safety of fertility-sparing treatments in atypical hyperplasia and endometrial cancer. So the first one was about cervical cancer, and the second one about endometrial cancer, which is the fourth most commonly diagnosed cancer with a rising incidence rate. Around 4% is diagnosed in an age frame where fertility preservation is key. Atypical hyperplasia is a premalignant condition treated in a similar manner. All guidelines agree that the first step should be hysteroscopic resection, but after that, the treatments can vary. Either oral progestins, hormonal IUDs, with or without metformin can be given. These differ in their risks and benefits. For example, the IUDs contain less hormone, but there's a risk of uterus perforation during application, and our aim to find the best fertility-sparing options for these women with the best oncological and fertility outcome. So the critical question, which is the best for these women with atypical hyperplasia or early-stage endometrial cancer, who already undergone the first step, the hysteroscopic resection. So we're investigating oral progestins, hormonal IUDs, metformin and their combinations. Just like in the previous one, we're interested in oncological and fertility outcomes. According to our hypothesis, the combination of the three of them provides the best results. It potentially can highlight the differences among the treatment options and help the decision making. So in summary, we have two ongoing projects. The first one about cervical cancer is close to submission, and the second one about endometrial cancer hopefully will be submitted in next year. I would like to finish with a quote from Marcus Aurelius. It's the truth I'm after, and the truth never harmed anyone. What harms us is to persist in self-deceit and ignorance. Thank you, and yeah, enjoy the lunch. Thank you.
Thank you very much. Any questions for the audience?
Regarding your first project,
yep.
You mentioned the disease-free survival. But what about the overall survival?
Sadly, so just as I told you, these data so we have limited data, and we can only include the recurrence rate, not overall survival, not recurrence rate, so nothing like time-based information. We only have like, we conducted these treatments for these patients, and now we wrote an article, and that's what we have. So we don't really have that option to include overall survival or any higher outcome.
Thank you.
So hi, great progress. I would have just one question, that after fertility-sparing treatment, if the patient gets pregnant, do you know if there is any concerns with the pregnancy, how you follow up, and any type of specificity by these pregnancies? Thank you.
Great question. So it's a huge debate whether the patients need cerclage or not, because of course these fertility-sparing surgeries reducing the cervical length, and that's why there's a higher chance of miscarriage and premature delivery. That's why cerclage is debated currently.
Just a short question. Do you know, or do we know the age range of the population which was examined in the studies? The age range.
Age range?
Age range, yes.
I mean, currently I think it's below 40, because all the assisted reproduction services, it has a limit. Of course, we can push it to the limit, but these patients, usually young patients who still wish to maintain their fertility, if it's already on the limits and on the edge, so patients above 40.
I mean, in the studies, what was the?
Yeah.
Okay, so they were under 40.
Yeah, I mean, basically, I think I included a baseline characteristic table. No, but under 40. That's the.
Thanks.
Thank you.